Hello, this is Dr. Bravo Thompson at Sylvester Comprehensive Cancer Center at University of Miami Health System. Today, I want to present two cases and the treatment experience in immune effector cell-associated HLH-like syndrome, post-treatment with cilta-cel. Cilta-cel is a chimeric antigen receptor CAR T cell therapy, which is a type of cellular immunotherapy that changes T cells so they are able to recognize and attack cancer. Several CAR T cell therapies have been approved by the FDA for treatment of relapsed refractory cancers, including multiple myeloma. T cell mediated hyperinflammatory responses, such as cytokine release syndrome (CRS) and immune effector cell associated neurotoxicity syndrome (ICANS, are now well established toxicities of these CAR T cell therapies. These toxicities are usually managed with anti-cytokine therapy such as tocilizumab and corticosteroids. However, as the CAR T field evolves, there is increasing recognition that CRS, especially severe or prolonged, can evolve into fulminant hemophagocytic lymphohistiocytosis, or HLH, also termed macrophage activation syndrome or MAS. Because of the overlapping features of CRS and the underlying hematologic malignancies for the HLH criteria, a new term called IEC-associated HLH-like syndrome, or IEC-HS, was established. In this case report, we present two cases of relapsed refractory multiple myeloma patients who were initially admitted for CAR T cell therapy with ciltacabtagene autoleucel, cilta-cel for short, or Carvykti for the commercial name. Both of these patients experienced the expected toxicities, including CRS and ICANS, up to grade 2. Patient 1, however, presented additionally with bleeding, increasing elevated ferritin, elevated LFTs, and severe thrombocytopenia on day 17, raising concern for IEC-HS. This patient was managed with a stepwise escalation of agents including anakinra, steroids, ruxolitinib, and a single etoposide 50 mg per meter square dose on day 30. As we can see in these graphs that I point here, in the x-axis we can see days after therapy, and in the y-axis we can see numerical values for different biomarkers. After all this stepwise treatment, the patient had resolution of biomarkers, decreasing ferritin, CRP, and resolution of symptoms. Patient number 2 had a prolonged ICANS grade 1 or 2, as described in the graph, in the setting of an underlying mild cognitive impairment at baseline, which dificulted the differentiation between the baseline impairment or toxicities from CAR T cell therapy. However, this patient, during their hospital stay, presented in addition with pancytopenia as well as an increase in ferritin. This prompted a bone marrow biopsy on day 35 that confirmed the IEC-HS. Treatment with a stepwise escalation of agents including anakinra, steroids, ruxolitinib, and a single dose of etoposide 100 mg per meter square achieved also resolution of symptoms, biomarker improvements, and even removal of findings of HLH in the subsequent bone marrow biopsy. This study is important because the manufacturer reports originally in the CARTITUDE-1 and CARTITUDE-4 studies that HLH mass occur only in 1% of the patients. However, we suspect that the real-world incidence may be higher. All of these HLH mass events in the trials had onset within 99 days of receiving cilta-cel, with a median onset of 10 days, and occur in the setting of ongoing or worsening CRS. Both of our case reports continue with this information as they presented around 30 days of infusion and on the setting of worsening ICANS or CRS. This means that our report offers an opportunity for prompt recognition and initiation of potentially saving therapy for IEC-HS, and our responses were consistent with the evolving literature and continuous need for updated criteria and treatment guidelines to address this poorly understood problem. Thank you so much.